All right, good afternoon, everyone. Welcome back to EMC 303. For the time being, we're going to meet in here. We got a little more room to spread out. That's good. The other thing is, as soon as if and when they get the AC fixed in 286, we'll go back in there. But I've got this reserved for the rest of the semester for 303. So unless you hear something different from me, we'll always be meeting in here. All right. So as we were going through, we did some work on some atrial arrhythmias, and so that's kind of the area where we're going to continue to go through today. Now, so what I'd like for you to do is let's go through and break down this particular rhythm that we've got going on here. So what is the rate? So say it loud because allergies has messed my hearing up. 80, okay, so that tells us this within a normal rate, okay? Rhythm, do you see a normal rhythm there? I heard somebody say no. What's abnormal about it? For which ones? And go ahead and get your laser pointers out, okay, because we'll be using those today. So what part of the rhythm, as far as the R to R's, are not lining up? Don't go dead on me now. Come on. You don't understand the question. Why? So the answer. Okay, good. So the question is, somebody says it's irregular. Why is it irregular? So go ahead. You just have to show us more. Yeah. Okay. Okay, very good. So it is irregular. Do you see a pattern to its irregularity? Good answer. Good answer. Because that's exactly what I would have said. You know, I think I see a pattern in the 6-second strip, but I would like to have more evidence as to whether it's there or not as we're moving through. All right, good. So what do you notice about the P waves? Are P waves there? Yeah, I see some heads nodding. That's good. So there are some P waves. Do all the P waves look the same? No, they are not. Now, tell me what you notice different about the P waves.
They're changing between short and pointed, tall and round, and then short and round.
Excellent. Very, very good. So here's the thing that I would point out to you, and I'm going to use the laser pointer here on my computer. So as you can see, that right there, that's going to be our baseline. So we are seeing a different one there as well. Okay, now you could potentially make the argument that this one looks different from this one, and there is a little bit of difference, but the similarity is so close that we're going to, for right now, we're going to say that those P waves look the same. Same way as we're looking at this one, and this one, and this one. Now, what do you notice about this P wave as compared to this P wave? Say it again? Very similar. What does the fact that it is so similar tell you, even though it looks different from the other underlying rhythm P wave? Say it again?
Possibly a pattern starting.
Okay, maybe. What else? Good. So it's coming from an ectopic site. Remember, ectopic means what? Different than normal. But you are exactly right. I believe, and I would agree with you 100%, that I do believe that even though these two beats here are coming from a site other than the SA node, they're probably coming from the same cell, all right? What do you notice about the space after the extra beat, the early beat, the ectopic beat? Yeah. So basically what we've got in here, going from here to here, this space in here is what is known as a compensatory pause. Hint, hint, hint. You will often, not always, but you will often see a compensatory pause after a premature beat. Remember that. That will serve you well if you do, okay? So let's move on. We've kind of talked about the P waves. What do you notice about the PR interval to the best of your ability since we're using a screen? Does it look like it is within a normal width? Gotta get up and move around. Y'all are too quiet. Gotta stare at you. Does the PR interval look like, for all of these, that it's within a normal width?
Yes.
Yeah, I would agree with you. Okay? And what is a normal width for a PR interval?
12, 20.
Perfect. 0.12 to 0.20. All right. What about your QRS complexes? All right. And a normal width for a QRS is what?
Less than 0.12.
Yeah. So anything less than 0.12, we say that the QRS complex is fine. All right. So if you saw this on your patient, and you're calling it into the hospital, what would you identify this rhythm as? Use it.
Premature atrial contraction.
You're half right. You're half right. When you have a premature beat, you're always going to have an underlying rhythm. So if we were to take this QRS complex out and this QRS complex out, and it were to be regular all the way across, Haley, what would you call this rhythm? Upright. So what? Normal sinus rhythm. Why? Because everything is normal. Okay? Even if you pull this one out and that one out, your rate is still going to be what? What's your rate going to be? 60. That's a normal rate. Okay? So everything about it is normal. So again, when you have a patient that has a premature beat or beats, you have to identify the underlying rhythm that comes along with it. So again, if this were on an exam, and I give it to you, and you identify it as premature atrial contractions, I'll give you half credit, because you only got half of it. You also have to identify the underlying rhythm. Now, what is a PAC? What happens in a PAC? It tells you in the name. Yeah, the atria, someplace in the atria contracts just way too early, all right? And as such, we see that here with this beat and with, hold on, this beat right here. Now, one of the things that I want to point out to you is this phase right here, this space, and this space. This is known as a compensatory pause. You will often see it, not always, but you'll often see it in rhythms that have premature beats in them. And remember, we're going to learn about premature atrial contractions. That's what you're learning about now. The junction also has premature beats, and the ventricles also have premature beats. This compensatory pause is basically built in so it allows the heart to kind of regroup and go, whoa, wait a minute, that didn't need to come from that site. So it allows the normal pacemaker, the SA node, to now begin to pick up. and to take over. And we see that actually happening because these P waves are close enough to looking to the same that we can identify that it's coming from the same pacemaker. And because everything's normal, we can work safely off the assumption it's coming from the SA node. Now, we get this extra early beat in here, and let me bring it over here. So we get this extra early beat in here, and it allows the heart, that compensatory pause allows the heart to kind of reset and regroup so that the normal pacemaker will take over and will pick up. Yusef.
How will we know the difference between sinus arrhythmia and a PAC?
Very good. With sinus arrhythmia, what you're basically going to see, and by the way, I approve this message. So what you're going to see on a PAC, so here's our baseline, all right? And I'm just going to draw hash marks. So we have our normal beat, and there's our normal beat, and there's our normal beat, and then all of a sudden we have an extra beat, and then when the rate is normal or slow is when you will primarily see that compensatory pause. When the rate is fast, above 100, the compensatory pause will either be more difficult to identify or you won't see it at all. So in this one, we would have a compensatory pause, and then it picks back up into the normal underlying beat. And then we have an extra one, early one, not an extra one, and then the compensatory pause. So this would be, we're looking at PACs right now. So this would be your PAC, and then this would be your PAC. Now your question is, how do we tell the difference between a PAC and a sinus arrhythmia? What causes sinus arrhythmia? Did we talk about sinus arrhythmia yet?
Sometimes when the patient's asleep.
Say it again now.
When a person's asleep, they have it.
So they can have it when they're asleep, but most of the time it's going to be when they're awake.
Breathing or movement or whatever?
Breathing does. What role does breathing have on the rhythm of the heart? Yeah, so we have the vagus nerve that runs through the heart. When we take a breath in, it puts pressure on the vagus nerve. This is going to be critically important a little bit later on because we're going to use the vagus nerve and the way that it reacts in pressure to slow the heart rate down when we've got patients that have got heart rates of 130, 140, 180. That can be life-threatening. But when we take a breath in, we increase the pressure in the chest. We increase the pressure in the chest. We put pressure on the vagus nerve. And as such, the vagus nerve acts as a brake. It slows everything down. When we exhale, what happens to the pressure in the chest? Yeah, guys are good. So, yeah, it relieves the pressure. The pressure in the chest is less. Therefore, the pressure in the heart is less. Therefore, the pressure on the vagus nerve is less. Therefore, what happens? Say it again.
The heart rate goes up.
Heart rate goes up. Yep, good. So, this is what it looks like on the monitor, okay? We're going to, this is your baseline. So just imagine those are equidistant from each other. This is inspiration. The more pressure we get in, the farther apart it gets. And this is expiration. Sorry, Kira. So you see that pattern. When we breathe in, the R to R intervals will progressively get wider. Why progressively? Because the more pressure we're taking in, more air we're taking in, the more pressure that we're putting on the vagus nerve, the more pressure, the slower the heart rate. When we're exhaling, we're gradually releasing that pressure, and the exact opposite happens. That pressure is gradually released, and now our R to R intervals get closer together, okay? Every one of us in here has some form of sinus arrhythmia. It's just a natural phenomenon in the body. For some people, it's more pronounced than others, but it's kind of that's kind of what we're looking at here. All right. So the whole concept that it's important for you to understand is, number one, the role that the vagus nerve plays. Make sure you're familiar with that, as well as what happens when we put pressure on the vagus nerve, as well as what happens when we release that pressure. Now, any questions on that before we move on? Speak now or forever hold your pizza.
An arrhythmia with a few waves stay generally similar the whole throughout, or what look like premature, kind of where it's different?
As compared, like when you're comparing sinus arrhythmia and a PAC?
If you're trying to find the difference between them.
Yeah, so the big difference is going to be is up here at the top. Well, it's not going to show up with this. Up here at the top, each one of those QRS complexes are still going to have a P wave. With sinus arrhythmia, each one of those QRS complexes are still going to have a P wave. The only real difference that you're looking at here is in sinus arrhythmia, it's an irregular rhythm, but there's a definite pattern to that, and it's tied to your patient's breathing. So that expanding and contracting, kind of like an accordion, that would happen faster the faster your patient breathes, okay? When your patient slows down their breathing, that expanding and contracting happens slower, all right? Good question. Anybody else? All right. Rate. That's a 6-second strip that you've got there on the screen. Say it out loud. I can't hear. All right, so we got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16. So I counted 160. Somebody said 150. We're close enough. Rhythm. Yeah, it's all over the place. It is all over the place, all right? P waves. Do you see them? Good answer. I heard, oh yeah. I heard sometimes. Both of those are good answers. Do the P waves look the same? Oh, interesting, okay? Hold that little piece of information there. What about your PR interval? Say it again.
Sometimes it's there.
Sometimes it's there. When it is there, is it consistent? No, it's not. Okay? Do you see a pattern to the PR interval? No, I see some folks shaking their head. No, there's really no pattern to the PR interval, because that's going to be really important, Jaquan, when we get into talking about AV blocks. Because there is a pattern to the rhythm, bless you, to the rhythm of the PR interval as far as getting wide or coming back down. So what do you notice about the QRS? Is it within a normal width? Yeah. So ladies and gentlemen, boys and girls, what would you call this particular rhythm? Say it again.
Sinus tachycardia.
Not sinus tachycardia. You got the back end of it right. Now, this is MAT, okay? So somebody, you become the instructor and you teach me now, what is going on with MAT?
There
Good. Very, very good. Yes. So they're getting a lot of ectopic beats that are coming through, and they're getting through. Okay? Now, just for fun, if this rate on this rhythm was 80, what would we call it? WAP, wandering atrial pacemaker. The exact same phenomenon is happening. We've got different cells in the atria that are firing. They're just not firing as fast. So that would make it wandering atrial pacemaker. With this one, because it is a tachycardia, now this is called multifocal atrial tachycardia. MAT and WAP are precursors, we'll talk about them in just a minute, are precursors to atrial fibrillation. They can be a big problem for your patient. So if you see this and it is a new onset, if you see this, one of the first questions, Ahmad, you should ask your patient is, has the doctor ever told you have an irregular heart rate? They say, oh yeah, I have bouts of AFib. Okay, then you go, oh, okay, you got it again. All right, not AFib, but you're seeing this and you're seeing this happen. But if they say, nope, I've never had any problems with my heart, then you're definitely going to want to report this to the hospital when you get there, because this is early indications of AFib. We'll talk about the danger of AFib when we get to it here in just a few minutes, okay? Everybody understand why this is MAT and the ramifications, okay? Good. All right, so let's talk about PSVT. Very quickly, again, where is the intrinsic pacing node of the heart? Where? And it sends its impulse out through the heart by way of and Bachman's bundle. Bachman's bundle. I'm going to go ahead and shut this door here because I'm going to disturb somebody right behind. Once it comes down, Bachman's bundle and the internodal pathways, it stops where? At the AV node. And the purpose of stopping at the AV node is? Yep. So it gives time for the atria to contract and for the ventricles to receive, and then the reverse happens. So we get top, bottom, top, bottom, top, bottom. Once it leaves the AV node, where does it go? Where? Bundle of His. What's the purpose of the bundle of His? Yep, so it's beginning to separate the impulse out into left and right so it can go down what? Say it again? Not yet. Left and right bundle branches. Excellent, very good. And then once it goes down to left and right bundle branches, it goes to what? Purkinje fibers. There you go. All right, so we're going to go over this every single class until you can vomit it out. So let's talk about PSVT. PSVT, paroxysmal supraventricular tachycardia. Basically what is happening is that there is a site in the atria that has gone rogue, and it is firing fast. Generally faster than 140 beats per minute, okay? Anything for this class, and you'll see different things in your book, anything up to 140 with everything else being normal. Normal P wave, normal PR interval, normal QRS width, a P wave for every QRS for every P wave. We're going to consider that anything between 100 and 140 as being sinus tachycardia. Anything above 140, we're going to call that a supraventricular tachycardia, and we have two flavors of supraventricular tachycardia. The first one we're going to talk about is PSVT, paroxysmal. Paroxysmal means a sudden start or a sudden stop. In other words, what this means is that while you're watching it on the monitor, you see it start and or you see it stop. It just kind of varies there. Now, PSVT can hit any of us at any age. I'm not going to take a poll because I, too, am a regular caffeine user. But at a certain point, if you're taking too much caffeine by way of coffee, tea, soft drinks, energy drinks, or you can go really, really crazy. You can actually buy powdered caffeine to snort. Some of y'all are shaking your heads way too vigorously. It can cause PSVT, okay? Even in your young age, okay? Doesn't necessarily mean that you've got heart disease, but it means that you have a chemical that is overriding the normal pacing. Some of the things that we can see in there is stress can cause it, okay? Overexertion. Nobody in here works too hard, right? I was telling my sequence class today that I get irritated and I get angry when I talk to friends of mine that complain about your all's work ethic. And I always tell them, you need to come see my students. Because not only are they full-time students, many of them are full-time employees somewhere else. And some of y'all are nuts. You have a part-time job as well. Okay? So it's kind of like, I have no complaints about the work ethic of y'all. But overworking, overexertion, stress, and caffeine can lead this to happen. Now, it can be caused by coronary artery disease, but most of the time it's not. Now, basically what we're going to see here with these patients that have PSVT is that they will have some type of chest discomfort. I say the word or the phrase chest discomfort because when you've got a patient that has PSVT, you will get every kind of descriptor known to man. It feels like my heart's doing flip-flops. It feels like my heart is skipping beats. Oh, my chest hurts when it beats. So again, that's kind of the things that you want to know and you want to do, especially when you're doing your patient assessment. Talk to some of the advanced sequence students who have had me in the EMC 110. I'm driving them nuts about being really good at patient assessment, and that's okay. Y'all are going to do the exact same thing, because if you can't assess your patient, you can't treat the patient, all right? So it can also lead to a drop in blood pressure. New term that you need to know, preload, P-R-E-L-O-A-D. Preload refers to the volume of blood that is delivered back to the heart, all right? When we increase preload, under normal circumstances, we're also going to increase cardiac output. When preload decreases, the exact same thing also happens under normal circumstances. In a situation of where you have a patient that has either an SVT or a PSVT, remember I said that their heart rate is going to have to be above what? 140. Good. Very good. The body really can't tolerate heart rates of above 140 for very long. Therefore, our preload drops. Why would preload drop the faster the heart rate gets, especially when it gets up above 140?
Doesn't have time to refill.
Perfect. Say that again for those in the back row.
It doesn't have time to refill.
It doesn't have time to refill. Okay, can I get an amen from somebody? All right, there we go. It doesn't have time to refill. And remember, unlike our Congress that often spends money they don't have, the heart cannot pump out blood that it doesn't have. So, preload drops, therefore cardiac output drops. And I say that being critical of all political parties. So, I never mind.
So how we been? It's like our heart rate's always up. So how does our body maintain? If it's over, because I know when I run, mine's like 178.
That's different. Your heart rate is what?
It's like 178 after I get on the sprint.
178. Not for very long. Are you still a sprint, though, right?
Yeah, so it's like you stop, you got time to walk back, and then it's like go against it.
So let me ask you a question. You're an athlete. What's your heart rate sitting still right now? What is it normal? 56, okay? Good example, all right? So if you've got someone who is really in shape, and we see this in particular with runners, if any of y'all others are runners, my daughter's a marathon runner. I don't know why. Nobody's chasing her. But if you are a runner, your resting heart rate is going to be really low. It's not unusual for elite athletes, Olympic athletes, to have a resting heart rate in the 40s. Okay? Why? Because your heart has become very, very efficient. Now, your heart rate, especially if you're a sprinter, will shoot up really, really quick because for a short time, it can handle that really, really fast heart rate because you're needing that to circulate to your muscles, especially the muscles in your legs and your arms. But if you came back and you finished running, and 30 minutes later you're sitting still, and you still have a heart rate of 178, Houston, we have a problem, and it's got to be addressed. So the big thing to keep in mind, again, this comes back to your assessment and your history of your patient. If you're looking at this young lady right here, you can look at her and tell her she's an athlete. So with a heart rate of in the upper 40s, low 50s while you're resting, you get her history, you go, oh, well, that's normal. Me, on the other hand, I don't know if you've noticed or not, but I'm not an athlete. It's okay to laugh. My heart rate's in the 40s. Please take me to the hospital. Again, because you got to look at the patient's history as well as that assessment, all right? And so that's perfectly normal for you. What we're looking at here is these patients whose heart rates go up really fast and stay up really fast. Now, what do we do for our patient? A patient can be considered stable with a PSVT, all right? And we'll talk about what stable looks like and what unstable looks like in just a minute. If the heart rate is up really fast, yes?
Could it be dehydrated?
Dehydration could bring that on. Yes, you're exactly right. Yeah, so dehydration could potentially bring that on. If our patient is beginning to have symptoms, they're beginning to say, my chest just kind of feels like it's skipping beats and flip-flopping. Their vital signs look okay, but we really don't want to do anything really, really dramatic or drastic. We'll do vagal maneuvers. Now, we'll talk about vagal maneuvers in a minute once we get through PSVT and SVT. If that doesn't work, then we go up to our next level. Now, ladies and gentlemen, remember, as healthcare professionals, always start with the least invasive, most appropriate intervention first. There will be times when you will go directly to electrical therapy for these patients, right? Because you're looking at them and you're going, you're not long for this world if we don't slow that down, and we slow it down right now. So you're going to skip the vagal maneuvers. You're going to skip the pharmacological interventions, which we'll talk about in a minute. And you're going to go straight to what's known as cardioversion. We're going to deliver a specialized type of shock, and we're going to stop the heart and hope that it will pick back up. All right? So that's going to be the thing that we're going to do as far as when we're looking at it. Again, when we're looking at our patient and we want to identify, is our patient stable or unstable in both PSVT and SVT. With a patient that is stable, that does not mean that they're not having any kinds of signs or symptoms. But what it does mean, Jaquan, is that if they're stable, the signs and symptoms that they're having are more of a bother than an indication of a life threat. Bless you. For example, man, my chest just kind of bothers me a little bit. I can just kind of feel it fluttering in my chest. That's a stable patient. If his blood pressure looks fine, his heart rate may be 160, But that's the reason it feels like his chest is kind of fluttering a little bit in there, okay? Now, if we've got a patient that is unstable, now we have kind of two options that we can look at. We can either go pharmacological with a drug called adenosine, or we can go electrical with a synchronized cardioversion, which we'll talk about in just a moment. Here is how you break down PSVT. Says the rate is 150 or higher. Remember, here it's going to be 140 or higher, all right? The rhythm is generally going to be regular, except where you see it start and or stop. Why is the rhythm regular? Fire away.
How long did, like, theoretically, how long did the heart last going, like, going from 50 beats per minute before it inevitably just...
It all depends. Yeah, let's pick a heart rate of 178. Okay, you're going to be able to tolerate a heart rate of 78 much longer than I'm going to be able to tolerate a heart rate of 178. Why? First of all, you're an athlete. Second of all, I'm not. Second of all, you are in shape. I am not. Third of all, your body makeup is mostly muscle. Mine is mostly Snickers. Okay? And so it all depends upon your patient. And once again, that's why you look at your patients. When you've seen one patient with SVT, you've seen one patient with SVT, and a lot of it has to do with their history and the physical that you're going to be dealing with. That's an excellent question. I love questions about assessment, okay? So as we're looking here, why is this part of the rhythm regular? What's going on with that? Why is it staying regular? It's the same reason why all rhythms are regular.
From the same site.
Comes from the same site. There's one cell that has gone off the reservation and now it's firing. Pew, 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 pew. Going really, really fast. That's why the rhythm is regular, okay? Now, what is your rate on this particular strip? Say it again? 170. Did you guys count these three over here? I see one person who's brave enough to nod their head. Did you count these three over here?
Did you even count them?
Say it again.
Did you even count them? Well, like, I know it's still.
This is a 6-second strip. Now remember, when we're using a 6-second strip, I'll come right to you, Yusef. When we're counting a 6-second strip, we count all of them. Yusef was the only one that was brave enough to go, yeah. So, see, he's not afraid to be wrong. He wasn't. Go ahead.
Does that count as a really tiny, or is that like
No.
interference?
No. So that, we're not entirely sure.
Okay.
Okay? In this particular situation right here, that would be what I would call FLBs, funny looking beats. We're not sure what that is. This could be interference. Now keep on in some of the, you tell me, what are some things that can cause interference on your EKG?
Road noise.
Road noise, movement.
Just want to say both of them.
Okay, what else?
Nation.
Say it again.
Nation.
What about your patient though?
You've been moving, you've been breathing.
Breathing. Okay, so we got movement, we got road noise, we got breathing. What else? Say it again.
Electronic interference.
Electronic interference. Although we don't have that much anymore because the cables are really, really shielded. But yes, that could be one. What else? Coughing could. Again, that could cause it. What else? There's two that are going to be real common that y'all have missed so far. Well, this is artifact. This is what we're looking at. What I guess what I'm asking is, what causes artifact?
The security coming off replacement of the just.
Tell me more. Placement where? On a bone or fat. Okay, on a bone or fat. What's the last one? What I don't have much of. Hair. Hair on the chest. You may literally have to take a razor when you're doing an EKG and shave the patient's chest, okay? Because you gotta have good skin to electrode contact. Sweat, fat, hair will cause this type of interference that we have right here. So we're not entirely sure what that is. Good observation, though. So we count everything on the 6-second strip. Do you see P waves? All right, so let's take a vote here. You got to raise your hand. How many people see P waves, especially in the tachycardic phase of the strip? Okay. How many people do not see P waves? Okay. Anybody see P waves for some of them and no P waves for other ones of them? Well, those of you that voted twice, kind of like they did in Chicago, and you voted last, you're right. So basically, we see some P waves in here sometimes. So for example, with this one right here, that little notch might be a P wave. I'm not willing to go out on a limb and say that it is a P wave. But I would tell you, if we come over there, over here, here's a P wave, okay? There's a P wave, there's a P wave. All of these P waves pretty much look close enough that we can say they're probably coming from the same impulse. Here, I don't see a P wave, all right? Over here, that might be a P wave, or it could be more interference as we've got going on here. The faster the rate, the less likely that you're going to be seeing a P wave, okay? If this gets up into 170, 180, 190, you're not going to see a P wave. Yes?
Do you not see the P wave because the ventricle repolarizing and the atria depolarizing is kind of combined into one that's overlapping?
That's exactly what's happening. So the atria is firing and is being swallowed up in the previous depolarization of the ventricle. So we're still got this offset that's going on, but it's happening so fast it can't be picked up on the EKG. Okay? For the rhythms that have, or for the impulses that have a P wave, what's your PR interval look like? Normal or abnormal?
What's the question?
Does your PR interval look normal or abnormal for the ones that you can identify a P wave on? They're short. I would agree with you. What else? Do we really get concerned with the P waves being, or the PR intervals being short? No, we really don't. Now, that will come in and be very handy and helpful for us when we begin to look at junctional rhythms that are generated by the AV junction. But as far as the PR interval being short, really not that much of a problem. Now, it can be a major problem when we're talking about PR intervals that are too long, okay? If you were looking at the QRS, what would you tell me as far as its width? Wide or normal? Say it again. I agree. Now keep in mind that when we measure our QRS, we're measuring from right about here to right here, not up here. But this is the end of your QRS. And so as you look and you go across, we're looking at about 4 boxes. It's borderline, but it's coming from the atrium, okay? So as we look at this, what we've got going on here is simply PSVT, rapid rate. Everything else is, quote, within a normal range or width, except we see this either start and or stop. All right? Questions on that? Okay. So as we're looking here at SVT, again, keep in mind with SVT, SVT is just exactly the same as PSVT, except you don't see it start or stop. So the same causes, the same things that come along can come in there. The same problem with reduction or preload comes in there. So PSVT and SVT are identical as far as cause and treatment and symptoms, except with PSVT, you see it do what? You see it start or stop. Okay, so as you can see here, this is going to be your PSVT. If you're going across, and again, your PSVT is going to be 141 beats or faster. All right? So, now, let's talk about what we do to treat it. In the brain, coming from the brain stem, we have a nerve that comes down through the neck, goes through the heart, passes through the diaphragm, and ends up in the stomach. That nerve is called the vagal nerve. The vagal nerve is very important. More research is being done because not only is it important from a physical perspective, it's important from a mental health perspective. One of the things that can happen with the manipulation of the vagus nerve is that when we are anxious, nobody's had any reason to be anxious over the last 3 to 4 years, right? Nothing's been going on. Just kind of a normal 3 to 4 years. But when you're anxious, one of the things that they tell you is to control your breathing. Well, what do they mean by control your breathing? You breathe in deep, you hold it, and then you breathe out slowly. What they're doing is, number one, we're increasing the amount of oxygen that's in the body, but you're also putting pressure on the vagus nerve. By putting pressure on the vagus nerve, it slows the heart rate down. In law enforcement, one of the things that they teach law enforcement officers in teaching them how to handle handguns, I would suspect is probably the same for those of you that are in the military. Watch your breathing, okay? Because you can't aim when you're breathing really fast like this. So you're taught to control your breathing, consciously control your breathing. Well, the exact same thing happens within the body when we've got a patient that's got SVT or PSVT. Remember, SVT or PSVT causes a drop in cardiac output because it does what? How does it cause a drop in cardiac output?
Doesn't allow for preload.
Doesn't allow for preload. It reduces preload. Has a negative impact on preload or some manner thereof. So what we got to do is we got to slow the heart rate down. How do we do that? First of all, we start with pressure in the chest. Yes?
Does it lower your preload, or is it more like your stroke volume? Because your stroke volume is increasing, your preload would be a side effect of that.
I love the way you're thinking. So yes, it can reduce your stroke volume. Most of the time, especially if it's in a young person, stroke volume will be fine. It'll still eject the same percentage. But what is happening is that the volume has dropped. So for example, let's make the math easy because I hate math. Let's say that your preload is 100 milliliters of blood, okay? And let's say that for your stroke volume, which is the amount of blood that is ejected every time the heart beats, let's say that it ejects 50% of that. So it's ejecting 50 milliliters of blood every time it contracts. And that's fine. You feel great with that. Your preload now is dropped, and now you're down to 25 milliliters of preload. Your stroke volume is still at 50%. Now instead of getting 50 milliliters with each contraction, you're only getting 12 and a half. And so again, volume matters in that regard, even though your stroke volume may remain the same. Good question. So as we're going through there, what we got to do is we got to slow this down. There's a couple of ways that we can do this. Number one is that we can have the patient take a deep breath and hold their breath. That may or may not work because a lot of these patients are going to feel short of breath because of anxiety or, again, one of the things that happens to our body is that when we have a reduction in preload, we also get short of breath. The other thing that we can do is we can tell our patient, please, I want you to bear down like you're going to have a bowel movement, okay? Push against a closed glottic opening, and that will automatically increase the pressure in the chest. Jaquan.
Do you know how long it takes for it to slow down?
All depends. Sometimes nothing that you do will cause it to slow down. Other times doing these vagal maneuvers or Valsalva maneuvers, whichever way you want to call them, will work really, really quickly. Word of warning, just a little bit from my experience, is that especially if you have an older patient and you tell them to bear down like they're having a bowel movement, be prepared. That's all I'm going to tell you, okay? So, Jaquan, go
Another
ahead.
question about that. So, if it was like a slowdown, like immediate, is that a problem right there? Like if
Well, yeah, because you haven't fixed the problem. Heart rate is still up. So, yeah. So, take a deep breath, hold it. The other thing that you could do is that you could take your oxygen supply tubing and cut it off and have the patient hold their nose and try to blow out through that tubing. That's going to increase the pressure in the chest. The other thing that you can do, and again, guys, remember, right now as EMTs, those of you that are EMTs, you can't do any of these things, so please don't do that. I don't want to see your name on the disciplinary list. Yeah, I saw that. On the disciplinary list of KVNs. These are paramedic skills. The other thing that you can do that is a little, well, can be considerably more dangerous is called carotid massage. And basically what you're going to do is you're going to take and you're simply going to put some pressure on one of the carotid arteries. What that does is that narrows the lumen, or the diameter of the carotid artery, increases the pressure in that artery, and that back pressure now goes back to the heart, which increases the pressure in the heart. Because remember, the carotid arteries are right here. They come off of what in the body? The aorta. And the aorta comes off of the heart. So we push pressure here, and the pressure in the heart is going to go up really, really quickly. Now, here's the thing. You got to be really careful. You got to listen to the carotid artery first. I would encourage you, even those of you that are now working as EMTs, go ahead and start listening to people's carotid arteries so that you can begin knowing what normal is. For those of you that are not yet EMTs, when you're in the lab, grab a stethoscope and listen to each other's carotid arteries. What you should hear should be kind of a normal blood passageway. If you hear what is called a bruit, B-R-U-I-T-S, spell it again, B-R-U-I-T-S, a bruit, you'll hear what sounds like kind of like a swirling noise. That means that there is plaque that is built up in the carotid artery. Instead of having a nice, smooth vessel to flow through, that blood is having to swirl around. Do we want to push on that or not? Why not? And go. Yeah, if it goes to the brain, the only career they've got now ahead of them is to be a politician. Did I say I don't like politicians? So again, we don't do that. Now, let me ask you this. If you hear a breathe over here, should you go over here and listen? Say it again. Yeah. So if you hear a brie over here, we've got calcium, a blockage over here. Should we consider going over here and listening? And if we don't hear a brie, can we use that artery? Youssef is saying no. Why do you say no, Youssef?
You can
Okay? But isn't that what we're wanting to do, to slow the heart rate down?
Well, if you're, I mean, you can still dislodge the clot or the blocked artery by increasing the pressure too much.
Maybe it would be a little far-fetched for pressure on this side, because remember, the pressure's coming here, it's going down to the aorta, and it's going to the heart. So that has to be an awful lot of pressure for it to now back up from here and to go up into here. Yes?
I would think no, because if one side already isn't functioning as it should, you wouldn't want to strain it more by
All right, that's a fair rationalization, but now remember, we're listening. The only thing that we can do is listen, okay? By the time y'all get into the advanced sequence, we're going to be teaching you ultrasound. So by the time you get in there, we'll be able to use a little handheld ultrasound that I've got down in my office. But right now, we can only listen. Yusef.
So I'm not gonna listen to the other side because putting pressure on that, you already have the blocked artery on the other side can lower blood perfusion to the brain.
So if you block off this one over here, that's definitely true. But if you come over here and you hear a normal artery that's, it's okay to do carotid massage on this side, okay? You just want to note in your patient care report that you listened to the left side, you heard a bree, and then you went over to the right side, okay? Now, if vagal maneuvers don't work, we move on up to a drug that is called adenosine. Okay, now we'll have a pharmacological section, but for right now, what I wanted to tell you is that adenosine basically stops the heart. You give adenosine, and you've got, when it works, you've got this patient that's tacking along 160, 170, 180, and then you push this adenosine, and you got to push it fast. We'll get in more detail on it later. All of a sudden, you go from 160, 170 to 180 to 0, and 0, and 0, and 0. And you may have a period of asystole for as long as 10 to 12 seconds. It's very uncomfortable for your patient, causes chest pain for your patient. So what I like to say is that the first time that you give adenosine, first your patient has chest pain, then you have chest pain, because you're looking and you think, I killed my patient. But then it picks back up. When it works, it slows the heart rate down because now the SA node picks up. We'll talk more in depth about adenosine later. Your third thing that we would do is we would use electrical therapy to shock the heart back into a normal rhythm. Again, we'll talk more about that one just a little bit later, okay? Now, as we're moving on, again, understand the difference between SVT and PSVT. The only difference is in PSVT, you see it start and or stop. Now, again, keeping with atrial rhythms, we have a rhythm that is known as atrial flutter. Within atrial flutter, what we have is that we have one site in the heart, in the atria, not just in the heart, one site in the heart that is firing really, really fast. The reason why this doesn't turn into either SVT or to MAT is that you have this impulse that comes down, and the AV node does not let every one of them go through. And that's a very, very good thing. Otherwise, it is possible that your patient could have a heart rate of 180, 190, or 200 if they all got through, all right? Generally, we're looking at some type of a problem with heart disease. Usually, it doesn't come about as a result of an MI, but quite often, a patient with heart failure or congestive heart failure will have atrial flutter. Atrial flutter. Now, atrial flutter, especially if it is fast, can cause a reduction in preload. There's that word again. Make sure you understand what preload is, because I will be asking you questions about that from now until the time you get licensed as a paramedic. It can have a negative impact on preload. Atrial flutter is similar to another rhythm we'll talk about in just a minute, known as atrial fibrillation, okay? If your patient is stable, we're just going to watch them. We'll get an IV started, maybe we'll do a 12 lead, and we'll watch them very, very closely. With your patient, don't worry about the pharmacological interventions on atrial flutter right now. But if it is really, really fast and your patient is having cardiac compromise, you can try to do vagal maneuvers. We do not want to use adenosine on atrial flutter. And we'll talk more about that when we get into adenosine itself. So if vagal maneuvers don't work on atrial flutter or atrial fib for that matter, then we're going, and it's really fast and our patient is symptomatic, then we're going to move directly into cardioversion, electrical therapy. Here's your criteria, okay? Your rate is you're going to look at two things on your rate. You're going to look at your atrial rate and you're going to look at your ventricular rate. Within each one of these are no longer P waves, but we identify them as big F waves. Okay? These are flutter waves. Okay? No longer P waves, but flutter waves. And we identify that as far as when we're describing it as putting the capital F, much like we see right here. So, each one of these is a depolarization of a cell or a number of cells in the atrium. The thing is, they all get blocked with the exception of that one right there, and it's allowed to go through. Okay? So what I'd like for you to do, first of all, calculate the atrial rate on this rhythm stream and tell me what it is. So what you're going to do, we're going to start all the way over here with this one. We're going to consider this one a 6-second strip. Count each one of those F waves. They look like the teeth of a saw. How much? 340. I can go with that. Yeah, I would agree with you. How long do you think you could live with a heart rate of 340? Less than a minute. Less than a minute. Because you had zero preload. Zero preload equals zero cardiac output. So you're going to be unconscious really quickly. The heart is really pretty cool the way it's designed. Is it comes in and it will block out all of those with the exception of that one. Now, somebody tell me what the ventricular rate is. $80. Atrial rate, 340. Ventricular rate of 80. Definitely got a mismatch there. It's a good thing that the AV node is doing its job in blocking out the vast majority, 75% of those atrial depolarizations. Otherwise, our patient would be dead. Okay? Now, again, you don't have P waves, but you have flutter waves or big F waves. And many times it's described as looking like a picket fence or the teeth of a handsaw. They're jagged, they're upright. When we're looking at that, if you don't have P waves, guess what else you don't have? You don't have a PR interval. So we don't calculate a big FR interval. We just simply said there is none. All right? Then the last thing, you can look at this one and see that your QRS is very, very narrow. Very, very narrow. Not a problem there. Right? So as we're going through and we're looking at this, this is what your atrial flutter is going to be. Now, one other thing that I want to point out to you, and I will always give you, at least in EMC 303, if I have, and I will, have an atrial flutter on your EKG exams, if you can tell me the ratio between flutter waves and QRSs, and you can be correct, then I will give you half of, again, of whatever that point value is for that particular question. So on, you know, if I give you 50 and this is 2 points, then I'll give you another point on that. So as we're going through here, what would you say is the conduction ratio of flutter waves to QRS complexes? It's kind of a trick question, so I'll just let you know ahead of time. Say it again? Yeah. What is the ratio? How many flutter waves do you see for each QRS? You would say it's like a 4-to-1 ratio, a 3-to-1 ratio, or whatever. What do you see?
This is a 4-to-1 ratio.
Okay. Now, let me ask you a question. I got 1, 2, 3, 4, 5 here.
Not
Told
exact.
you it was a little, kind of a trick question.
So it's 34 to 8, so it's like